Members for this opportunity to share current evidence on integrated care for HIV and NCD that is relevant to Uganda. My name is Josephine Birungi. I work as a senior scientist with the MRC UVRI in Entebbe. My presentation will talk about some of the policies in Uganda and other guiding documents that support integration of HIV and NCD, different publications on integrating HIV and NCD, including the different models I published, then the ongoing research or any future additional evidence that we should expect, and maybe we can launch into discussion after this. In terms of policy and other guiding, there's this paper on integration of non-communicable diseases and HIV/AIDS management, a review of healthcare policies and plans in East Africa that was done by Adeyemi, published in the BMJ Global. In this paper, they highlight the documents from different East African countries. For Uganda specifically, document number 1 is the Uganda National Health Policy that recognizes the growing burden of HIV and NCDs and has one of its guiding principles that curative, preventive and promotive services shall be provided in an integrated manner. Then the other document is the 2020 Uganda Consolidated Guidelines for the Prevention and Treatment of HIV and AIDS, which provides a clear statement supporting integrated management of HIV and NCD by recommending that stable HIV patients with NCD and without any complications should be seen in a single appointment by same clinician with patient records available in the same location, and that both HIV and health education should be available in the country. We also have the goal of the Uganda HIV/AIDS strategy. It's another document, 2016-2020, which is to move towards holding HIV incidence, HIV and AIDS related mortality, morbidity, and stigma or discrimination. But one of the strategic actions in this document is to strengthen integration of HIV care and treatment within the healthcare programs. So they state, integrate HIV care and treatment with maternal, newborn, child health, sexual and reproductive health, rights, mental health, and non-communicable or chronic disease. This is on page 27 of the document. And the proposed integration would occur across all levels, including community and home-based care, but no further details are given on how. So this is just a snapshot of the documents that are in support of integration. The other evidence we have is work done by Mr. Martin Mudu, who is part of this team. Dr. Martin looked at hypertension care cascade at a large urban HIV clinic in Uganda, and they were using a mixed methods, using the COM-B model, and they found that the prevalence of HTN and among PL-HIV is high, but the HTN hypertension care cascade was suboptimal in this successful clinic. So there are many HIV successful clinics whose care cascade for NCDs has gaps, and they said to close these gaps, models of integrated HTN HIV care are urgently needed. And the findings from their work provide a basis for designing contextually appropriate interventions for hypertension and HIV integration in Uganda and other low and middle income countries. So they further illustrate this in the hypertension care cascade, where they look at 24.3% that were diagnosed, only 1% was initiated, and of the 1%, 15.4 were the only one that were retained in care, and 15.4% also monitored. Eventually, only 5% were controlled. So improving the quality of life of persons living with HIV would require more than just virologic suppression, and that's that we control even hypertension, we control diabetes, and this is really in support of. The other work is the work we did with MRC that will soon be published in the BMJ Open, which talks about integrating healthcare services for HIV infection, diabetes and hypertension in sub-Saharan Africa, a cohort study. And in this cohort study, we're looking at feasibility, acceptability, and costs of integrating HIV, diabetes, and hypertension care in 10 facilities, 8 public health facilities, and 2 NGOs. I'm glad to inform you that integrated management for chronic diseases is feasible strategy, and in terms of the integration of HIV services, diabetes and hypertension control reduce both the health services and the patient or household costs substantially. And so it's likely that the integration is an efficient and equitable way to address increasing burden of financially vulnerable households among the aging populations in Africa. So I went further to look at the different papers published on the models of care, and this is work by Duffy and team that found 3 models used for Model 1 is facilities that originated as HIV sites evolved to accept NCD patients. Patients were brought into services via in-house diagnosis, referral from external services, and case findings via community, NCD and HIV screening. Patients were enrolled into care if they have HIV or NCD. Dual diagnosis was not necessary. As long as you had one of the conditions, we enrolled in this HIV clinic. Then the other model 2 was the HIV integrated into the NCD services at primary health care centers. So the patients that were accessing NCD services at those centers were offered HTC, and whoever tested positive was offered enrollment into the HIV program that was still located within the city. Model number 3 is the simultaneous introduction of integrated HIV and NCD services in one clinic. This is the model similar to what we used in the MRC UVRI study that I'm also going to share after. So in this model, the patients were referred to a health facility if they were in the community, and when they came to the clinic, they put them together. So it was a chronic care clinic. It was not HIV, it was not NCD, but it was a chronic care clinic. It has both those who had HIV and those who had NCD. So this is the model that I was explaining. So patients in the MRC UVRI study, which we call the MOCA, and the MOCA model, we moved into the HIV clinic, the diabetes clinic, and hypertension, and then we created an integrated clinic. We could not do away with the other clinics because some patients we knew would not want to come to this integrated clinic. So we had 3 to 4 clinics running, but this is because we were trying to test out. So that's the model, one-stop chronic care clinic, irrespective of your HIV status, and that is the model number 3 that Duffy explained. Then also another paper by Njuguna that identified 5 models of integration, but these were also looking at. We shall not concentrate on the screening, and then they were also looking at differentiated care, HIV and CD integration, the community, and then population level. But the model that we may be interested in as a team is the model number 3, where they were leveraging HIV platforms to work towards comprehensive primary care, and they were bringing in NCDs. That's what this busy pictorial is. So what's the research out there on that is ongoing that will also inform us as we carry on our work on integration? We have research by IDRC, who are doing the same work similar to what the Dr. Martin and Mudu did, that is integrating HIV HTN, leveraging the HIV platforms for hypertension control in Uganda. This is on a larger scale, and in over, I think, 52 districts. So that work will inform us, and they're looking at effectiveness, barriers and facilitators, and also cost. Then we have work by MJAP, still led by the team that Mood works with, about strengthening the blood pressure care cascade and treatment cascades for Ugandans living with HIV. This is the PLESA Uganda project, and this is to basically build on the work that they saw in the previous work that I presented. To see, this is only in Kampala and Wakiso. Dr. Martin will tell us more. And then the other work that is being done now also is the cluster randomized control trial by MRC and UVRI. Like I said earlier, the work that I'm part of, the first one was a cohort study in 10 facilities, but now we have gone into a cluster randomized control trial in 32 facilities, and we are looking at integration of these services, comparing them with standard of care. So this is a paper on the protocol that we also have a paper that is looking at the process evaluation, strengthening integration of chronic care in Africa. And this process evaluation will give us with the processes as we work to strengthen integration at the various facilities to improve the quality of life of persons living with the chronic. So in conclusion, there is evidence to support integration of HIV and NCD, that's policies and the gaps that have been identified, the information on feasibility, acceptability, and the costs. We also have information on different models of integrated integration of HIV and NCD that have been published, and with the we can also feel comfortable that research is still ongoing and to be able to inform us in future. Thank you very much for listening once again, and I am happy that we are taking this direction. Thank you, Chair.